Good afternoon, ladies and gentlemen. We're going to begin our webinar now. My name is Steve Love. I'm President and CEO of the Dallas-Fort Worth Hospital Council. We thank you for participating in this webinar today. It's a very educational webinar, and we're hosting it in coordination with the University of Texas, Arlington, and Care and Prepare. They are associate members of the council. Today's topic, advanced care planning, AI-based quality and cost analysis of THCIC claims data. This should be a great discussion. The speakers are going to detail the impact of a multi-year study between University of Texas Arlington and Care and Prepare involving advanced care planning. As you know, it's a service that helps prepare patients for the last part of their lives. We've got 4 speakers today, and they include Leah Wingard, Executive Director of Care and Prepare, Dr. Mary Tietze, who's a health informatics professor at UT Arlington, Dr. Mahmoud Jawad, Associate Professor of Instruction at UT Arlington, and John Nguyen, Health Informatics Intern at Care and Prepare. We're really looking forward to this presentation. One administrative note, please feel free to put your questions in the chat box or the Q&A box, and we will try to get to these before the end of the program. Thank you again for being here, and it's my privilege to now turn this over to Leah Wingard.
Thank you, Stephen. I really appreciate your kind remarks and the opportunity to address this topic today. Well, our goal is for advanced care planning for all. And in 2019, the board realized that to achieve this, we would need to have more people that we collaborated with as individuals and as organizations. So today I want to introduce you to the dream team that came from that. UTA College of Data Science and Data Modeling, Dr. Jawad. UTA College of Nursing and Health Informatics, Dr. Mary Tietze, and her intern, John Nguyen. We also had interns for data, Colin Clark, Amani Salim, and Julia Kim. Our board has helped us every step of the way, and we are grateful for their help in all of this. So here's our roadmap. Let's talk about this. We'll begin briefly by defining advanced care planning and reviewing what decades of research tell us about how ACP influences patterns of care. Next, Dr. Tietze will walk through the study itself, our data source, patient cohort, and methodology, so you can understand exactly how we approached the analysis. Dr. Jawad will then examine the results of our AI-based quality cost model and discuss what those findings might mean for healthcare organizations seeking to improve patient-centered care. From there, we'll shift from research to implementation. John will discuss and introduce the Care and Prepare app and how we're using technology to support clinicians by improving ACP workflow. You'll hear next from Dr. Barker about the evidence-based implementation in his clinic, followed by an overview of Your Health Your Way questionnaire and how it helps translate patient values into meaningful healthcare conversation and documents. We'll conclude by exploring the potential impact of ACP at both the individual and societal level, and then we'll look at, if we piqued your interest, we might have some more information that would be right up your alley. So, what is advanced care planning? Well, it is the process of translating patient values into clinical direction before a health crisis occurs. And it is a structured face-to-face conversation. It's a voluntary interaction, and we're going to center on discussing concepts around advanced care planning. Most of the time, people can identify a champion, somebody that could speak for them, and they'll document that in a medical power of attorney. You've also probably heard about living wills. The official title is Advanced Directive for Physicians and Families and Surrogates. Sometimes it's appropriate when a patient says, I don't like the idea of CPR. Occasionally, we will help them with understanding what an out-of-hospital DNR is, along with a POLST, which is actually a medical set of orders that will accompany them. All of these center around quality of life priorities that they have, what their goals of care are. Sometimes they'll want to talk about the disease trajectory, as well as, what would hospice or palliative care look like for me? Now, at this point, you may be asking yourself, do I have to complete a formal document, or could I bill for an encounter? You can bill for just the conversation because it's truly a gift to the patient as well as the family that may be there discussing what their wishes are. These services can be provided by a physician or a multidisciplinary team. The most important thing is that there is great ACP instruction. We'll talk more about that later. Can you bill for this? Yes, you can. It can be done on the same day as a standard visit. And for Medicare, these are the codes that you would use. Medicare also, this is an annual wellness visit that you can bill for this. Now, if you have a conversation for 15 minutes, you've done your first pro bono consult. After 16 minutes, then you can bill CPT code 99497. And if you have, or if you need additional time, that is also an option that's available in 99498. So you might ask yourself, what would happen if we actually made advanced care planning education routine? Well, the Coalition to Transform Advanced Care actually did that a few years back. And this study is really seminal. It looked at what does advanced care planning do for expenditures? And nationally at that point in time, the charges were $79,000 per patient in the last 2 years of life. But in La Crosse, Wisconsin, they were only around $49,000 per patient for the same time frame. What happened that there was a 40% lower end-of-life cost? Well, ACP is routine, it's not rare, and when it's normalized, it will affect behavior. One of the things that really stands out for me on this is not treatment limiting by providers. This is actually compliance with the patient's advanced care planning. It's what they want for their health. Well, that was pre-COVID. What happens post-COVID? Does this still hold true? Well, Dr. Chen out of USC, she did a study on when Medicare reimburses for advanced care planning and patient-centered goals. What they found is fewer in-hospital deaths, there were lower ICU usage, and lower inpatient spending. It's also important to note the effects were strongest for high-risk populations. So Medicare payment for ACP may improve end-of-life quality of care while reducing late hospital use. This study comes to us from China, and it looks at advanced care planning in cancer treatment. It's a meta-analysis of 14 randomized trials. And what did they find when advanced care planning changed? Well, they had an 8-time increase in completion of advanced directives, 40% increase in palliative care utilization, and the results were real and measurable. Could this actually help clinicians? According to the Journal of Pain and Symptom Management in 2023, they had did a systematic review and showed where high quality ACP is associated with less moral distress for clinicians, better quality of communication, and higher professional satisfaction. So ACP can reduce moral distress for clinicians. It's helpful for patients and for healthcare providers. Well, this is one of my favorite studies. It actually comes from the British Medical Journal, and it takes a look at ACP and the relationship with facilitators. One of the strongest findings across ACP research is that patients don't simply respond to the information, they respond to the person facilitating that information flow. Patients describe ACP experience when facilitators are compassionate and patient and willing to create a safe space for discussing topics. So trust and relationship building are not soft skills, they are core competencies that directly impact and influence whether patients will engage in a meaningful conversation. Finally, there's no one size fits all for ACP conversations. The most effective facilitators focus on the patient's coping style, their health literacy, their cultural background and family dynamics, as well as their willingness to engage in the process. This is a completely volunteer experience, and skilled facilitators really shape the patient experience. And now what you've all been waiting for is data. So I give you Dr. Mary Tietze.
Okay, so at UTA, that is where I am from, and we are regular users of the THCIC data. And that stands for Texas Healthcare Information Collection Data. We're in partnership with the DFW Hospital Council, for that ability to do that. As such, this is how we have the students get very familiar with it. The students from the data science, as Leah mentioned, Colin Clark, actually did the initial cleaning of the THCIC data that we pulled. Amina Salem, she actually did the coding for actually being able to pull all the cancer diagnoses out of the data that we were using. And then Julia Kim, you'll see her bar charts and how she created the distribution visuals that we have today. So I thank them for that. So basically, for those of you that may not know, that THCIC had its legislative origin, as you can see in the upper left, in the 75th Texas legislature. It's required. That was in 1995. It is part of the Health and Safety Code, Chapter 108. The administrative agency for the THCIC data set is the Center for Health Statistics, the data Texas Department of State Health Services, and they are the ones that house and manage the data. The mission overall is what I love the most, and it is about collecting, validating, public reporting of the healthcare data across the entire state of Texas. This helps the state of Texas understand the health status of the population and strategically plan for it. In the lower row, you see that the scope, it involves inpatient discharges, outpatient visits, emergency departments, and also HMO HEDIS data as well. So the overall purpose of all of this effort for THCIC in Texas is it empowers consumers because that information is readily on the website for those that are interested. Researchers use it like us. Policymakers are looking for it for guidance, and health professionals would have transparent access to healthcare data itself, as many of the hospitals in the DFW area actually use the data as well. Next. Who reports to THCIC? The scope is general hospitals, as you can see there, that are all licensed in Texas. The next type is ambulatory care centers. The next type is the freestanding emergency departments, not just the ones associated with the hospitals. And then the fourth types are, like I said, the HMOs where the quality data is also provided. Next. This is the fun part, the diagnoses, the data that is detailed for our analysis. And you'll see more of that in our next slides. Diagnosis, ICD-10, clinical modification codes. Every patient has them in all their admissions and discharges. Procedures, most patients are going to have procedures conducted. So the various types of procedure codes are also included in this data. This is where we were able to search for the CPT codes that Leah mentioned in terms of services that can be provided to the patient. Patient demographics, very important, as you'll see, the age, sex, race, ethnicity, and zip code. So we can see where the highest needs are. Now, if this is de-identified data, for the most part, whenever we're using it, you have to have a special case to actually see anything more than de-identified data. And we never use more than, we always have de-identified data. So then when this where it says protects the low population areas, when there is not more than 5 diagnoses in a particular area of the data, that the data gets masked, the zip code does. So it is protection, and it is HIPAA compliant. The charges then are very important as well. It is the total billing for the episode of care. In this case, for us, it's the inpatient stay, but it could also be the outpatient stay, the ED visits, and so forth. And it is the charge, not the cost. So keep that in mind. It's what gets awfully sent to the health insurance company for the most part. Payer sources, extremely important. What's the difference between Medicare, Medicaid, private, commercial, and self-pay? Charity, a big analysis for most of us to keep track of. So that's in there too. And then the facility information, the NPI numbers of the facility, the name of the facility, the county of the facility where they reside, the trauma levels, other characteristics of the facility. Next slide. So here's one of the examples that drive us, and that was provided by Julia Kim. It basically tells you the top cancer diagnosis in our data set, which was malignant neoplasm of the endometrium in this particular case. But let's look at our sample. So what we're looking at on the far right of our demographics, we had 2,580 encounters to evaluate. We had an average charge there of 45,000 or so. A standard deviation, now for those of you in statistics and the students that are watching today, that is how much variance is there in the data. Whenever the standard deviation is larger than the mean, there's a tremendous range and much outliers, which is what we see here. So therefore, it is the median that really tells us what the average or the middle charge is. It's the 50th percentile. It's the middle charge of $23,000 per episode. Then we had our age. We went all the way back to 18 to 90 plus for who's included in this cohort. And then the most of the patients came from the 55 to 75 range of age, which was about 54% of the cohort. Then most of them, it was split pretty much between females and males, but males had a few more in terms of their 50% representation. In terms of race, we had 73% white, and the rest were Black, the other races, and other. Ethnicity, 84% non-Hispanic or Latino. The other remainder was Hispanic and Latino. And then this again was just Tarrant County. We started small so we could manage and understand and validate the data that we were looking at most closely. And it was only for year 2023. Next. The zip code is very important to us. And this is where we want to do a little bit more deep dive in our next study that we're going to be able to, that's our second webinar we sort of talked about. And then what is it about zip code 676137 and 676180? When I looked at those, the first top three, I thought, oh, maybe there's more poverty, maybe there's more other factors that might lead to those. And there really wasn't. So we really do need to do a dive into what it is about these particular top 20 zip codes where most of the cancer cases came from. And that leaves lots, sometimes with research, you find more questions than answers. And that's a good thing because you want to keep looking. So just to summarize, our methodology involved using the THCIC readily available data to us for the data from 2023, and specifically for Tarrant County because we knew the data, people that were involved with us from Leah's area, the Care and Prepare, were familiar with Tarrant County in general. We assessed the cancer diagnosis and the distribution of them to understand that. Then number 3, we identified cancer-based records and their characteristics, as you saw a little bit about that as well. Dr. Jawad will go into that more. Number 4, we deployed predictive analysis using AI modeling, and that's to be the next steps here. But also, most importantly, we presented the results to clinicians associated with Care and Prepare and did the final tweaking of that adjustment of the model. And now I'd like to have the fun part even more fun than mine, and that is to talk about AI-based modeling. Dr. Jawad.
Thank you, Dr. Tietze. In this part of the presentation, or in this predictive analysis, we lead with the median, as Dr. Tietze talked about it a little bit, which is the 50th percentile, and not the mean. So catastrophic stays do not inflate it. The defensible bottom line is a 2.16 or $2.16 million annual savings opportunity just from offering advanced care planning to the top 15%. And cost is only half the story. That same approach also improves quality care. Next. This table shows both views together. On the mean, about $14,000 saved per patient. On the median, about $5,600. Across all 387 patients, total charges fall from 40.7 million to 35.3 million, about $5.4 million in difference. Remember, the without ACP column is from the real data. Observed charges, the with ACP column is modeled. So treat the right side as a projection. Next. Here is how the model was built. The data is THCIC discharges. We have 2,580 rows, which are the cancer patients, de-identified, validated by our ACP board. 2 steps for the analytic approach: logistic regression to find high cost, high mortality patients, then a Monte Carlo simulation to project the savings. Using literature-based reduction, one honest caveat: no patient received billed ACP services, so every with ACP number is projected, not measured. Next. This slide is the whole model on one page. Read it left to right. We have predict, classify, act. Stage 1 on the far left is the input 11 patient level variables pulled straight from the THCIC discharge record. They fall into 3 buckets. The first one is the demographics, like age, sex, and pair. Next bucket is clinical burden, like number of comorbidities, metastatic disease, and critical illness. And the encounter itself, whether it was an ED admission or involved surgery. The next one on the predictive model, stage 2 feeds those 11 variables into a logistic regression that returns a single risk score, the probability a patient would benefit from advanced care planning. And the model holds up a test of area under the curve, AUC of 0.91 and 0.90 on a 5-fold cross-validation. Trained class weighted across all 2,580 discharges. We draw the line at the top 15%. Stage 3 defines that we mean by would benefit. The dependent variable is yes if the patient died in the hospital, was discharged to hospice, or had a stay at the least 14 days that also ran past $50,000. That sorts everyone into 4 risk tiers, and we flag the top 15%, 387 patients, for outreach. Stage 4 is the payoff, applying a literature-based 25% cost reduction to the $40.7 million. These 387 patients generated projects about $5.28 million in annual savings. And even on the conservative 15% assumption, $3.17 million. So in one trajectory, 11 variables in a ranked list of who needs ACP most out, and a defensible dollar figure on the other end. Next. This is the core finding. The very high and high tier, the top 15% of patients account for about a third of all inpatient charges, and their mortality is far higher. 10% in the very high tier versus almost 0% in the low tier, which is in the far right. Roughly 80 times higher. The takeaway, advanced care planning should not be spread evenly. Target the small group who needs it most. Next. To be conservative, I switch from the mean to the median, the typical patient. So outliers do not inflate it. On that basis, savings are about $5,600 per patient and $2.16 million across the program. Per patient cost still drops to nearly 17%. This is the number I would take to the leadership, smaller but defensible. Next. As I said, with the median, not the mean, so catastrophic stays do not inflate it. The defensible bottom line again is a $2.16 million annual saving opportunity just from offering advanced care to the top 15%, and cost is only half the story. That same approach also improves quality of care, and the saving is real, but only if ACP is easy enough for busy clinicians to do every day. That is when John Care and Prepare app comes in, taking ACP from paper to a streamlined digital workflow.
Thank you, Dr. Jawad.
Thank you, John.
Back in fall of 2025, I was a student of Dr. Tietze and was given an opportunity to intern under Leah at Care and Prepare. My task was to develop a clinician-facing mobile app to help reduce manual data entry by streamlining the company's paper-based consultation process. Developed through Google AppSheet, the app would eliminate the need to manually type paper consultation into a computer at a later time. The app additionally would save data entry time because it is set up with logic to autofill information as questions are answered to save time. In the following slide here, this is a look at what you can expect when you open the mobile app. The left image is the main page, which will list the most recently submitted consultations from top to bottom. You can open a new consultation here by pressing New Consultation on the bottom left of the main page, which opens up the form shown by the image on the right. I made sure the form mirrored the original paper layout for easy adoption. Slide. During app development, I found that the company was operating on a local Excel file, so I offered to clean, format, and migrate it to a centralized cloud database. Afterwards, it was possible to connect it to the mobile app and make sure completed consultations automatically populated the database. Following that, Leah had told me a previous intern wanted to integrate Power BI for data insight, so I had a look and was able to integrate the new cloud database with my own Power BI deck to deliver automated key performance indicator dashboards, which provide insight into the patient data and specific points of interest such as outstanding payments or days since payment. By the end, I went far beyond my initial task and made a completely automated app to database to business analytics data pipeline despite having little experience. It was very rewarding to see the project all come together. This is a simple visual guide of the automated data workflow that I developed during my time at Care and Prepare. Starting from the mobile app on the left, each completed consultation will create an entry in the patient database shown by the middle image, which then goes to Power BI for business analytics. I also recently added a function that allowed the mobile app to be able to generate a monthly invoice. Once again, I'm very grateful to you two, Dr. Tietze and Leah, for this opportunity to further develop my skills. Back to you, Leah.
Thank you so much, John. You exceeded all of our expectations, and we are truly grateful and thankful for your contribution to this project. Well, Dr. Jerry Barker is our Chief Medical Officer, and he's also a founding partner at Texas Cancer Specialist, graduate of UT Southwestern and residencies at University of Iowa and Washington. He also did head and neck fellowship at MD Anderson. And he has been instrumental in helping us grow and implant and embed into his radiation oncology center. So he is going to introduce two patients to you. It's a miniature case conference. He is not typically the patient's first stop on their cancer treatment plan. And I think it's important to provide you that context, especially when it's a particularly bad quarter, as well as maybe year for very rugged cases. There's an old adage that says mind a gap. So he is describing said gap, and we will share more excellent way after this video.
I recently met with a patient who was diagnosed with cancer about 3 months ago. It was pain that led him to his doctor and ultimately to a diagnosis of cancer. And we talked all about biopsies and scans and surgery, and we talked about what he had learned from all the other doctors that he had met. We talked about plans for his ongoing cancer treatment, and ultimately he agreed to move forward. And at the end of the visit, he asked me, well, what about my pain? He had been in pain for 3 months, and literally not one person had solved the reason he had visited a doctor in the first place, the thing that he wanted solved. I saw the same thing with my wife a couple of years ago. Sharon was diagnosed with a bad breast cancer. And in order to live, she needed a lot of treatment, surgery, radiation, chemotherapy, immunotherapy for 12 months. And over, I watched her access a broad swath of the healthcare system in Tarrant County, multiple doctors, nurses, clinics, hospitals, operating room, lots of staff, to a person. Everybody was great and busy and efficient and competent and kind. But literally not one person ever asked or answered the biggest question she had from the moment she was diagnosed. Am I going to die? What would that be like? What will I be like after all of this treatment and this cancer? Is my life going to be worth living after all of this? Am I losing control of my life? Is my family going to be okay during and after this cancer and cancer treatment? These questions were always under the surface, like the elephant in the room, and not a single person in an entire year ever helped her to ask or answer those questions. With God's grace, she is cancer-free today, but she is scarred. She has physical scars from cancer and cancer treatment, but she has emotional scars, partly from wanting her fears to be addressed by the myriad of healthcare providers she interacted with. Yet literally every single person ignored those fears. You know, doctors and hospitals and healthcare in general, we're not getting great report cards right now. In March of 2026, a Gallup poll found that healthcare has overtaken the economy as the top domestic concern for Americans for the first time in years. About 25% of patients report their trust in healthcare organizations has declined in just the last year. There was an Experian survey from March where both patients and providers feel that healthcare today is often unaffordable, poorly accessible, and much more profit-focused than patient-focused. And the healthcare workforce in America feels this too. Multiple recent surveys have published high rates of nursing or physician burnout, like 40 to 50%, leading to high projected rates of early retirement, like 30 to 40% in the next 5 years among healthcare professionals. So, not surprisingly, an April 2026 Pew Research poll found that 36% of Americans turn to social media and or AI chatbots for health information. And for young Americans, it was 52%. Why are these things happening? I mean, obviously there are multiple complex causes, but I would suggest that one symptom is that we are just often missing the mark of what patients actually want from us. And I don't believe it's because the American healthcare system or healthcare providers want something less for our patients than full restoration and healing, body and soul. I think instead, the problem may be what's being described as the quote, systemic industrialization of healthcare. That can include bureaucracy and red tape, declining reimbursement, staffing shortages, unrealistic expectations, and moral injury. Doctors and staff don't like being turned into factory workers, and patients don't like being treated by factories, especially ones that don't even make a good product. Today, we want to talk with you about a topic that has the power to undo some of that systemic industrialization of healthcare. This is just one small piece, but this is something important that, simply put, powerfully restores humanity to an industrialized healthcare system. We want to talk with you about advanced care planning. You'll hear us refer to that as ACP over and over. Everybody knows what ACP is supposed to do. It's supposed to help someone prepare ahead of time when it's easy for a future time when healthcare is hard. Maybe because I can't make my own decisions, or because the decisions themselves are difficult, or because they involve things I don't want to think or talk about, or because they bring up painful things in my life or the life of my family, et cetera, et cetera. All of us in healthcare are trained. This is a good thing to talk about. Many studies have shown that ACP pretty remarkably improves outcomes, lowers costs, eases patient or family anxiety, and honestly ingratiates patients to healthcare providers and systems. It's just really tough to do it, especially when industrialized healthcare is so busy making widgets that even the idea of sitting down with a patient or family and having a long conversation for a goal that may be in the distant future seems ridiculous. And believe me, I get it. My appointment schedule is completely full every day. My staff are stressed, reimbursement's going down. I'm not getting any more staff. So there's this tension again. We know this is beneficial. We've experienced enough of it to see the benefits. It's just impossible to accomplish because we're all so busy making widgets. Well, I have the joy of working with a not-for-profit called Care and Prepare. And for 2 decades, this group has worked to promote ACP for all of our neighbors here in Tarrant County. For many years, we tried to educate and encourage and inspire healthcare professionals to do high quality ACP routinely. It just really didn't work. We learned that trying to inspire and encourage a stressed and burned out healthcare culture to add ACP to their daily list failed to get a lot more patients' ACP needs met. Great goal, great idea. It just wasn't getting anything done. So in 2019, we knew we were providing great education, but we really wanted to move ACP from the classroom into the actual clinic. So we began a pilot study where our little nonprofit shifted from educating to actually doing ACP in the clinic. So today you're going to hear how we've done that by embedding ACP in a real oncology clinic, not a theoretical one, by collaborating with hospitals, payers, and community partners, and by showing that you can have truly patient-centered care in the real world of tight schedules, staffing pressures, and financial constraints. The patients seem to really love it. Honestly, it's probably some of the most important work going on in my office right now. It's changing entire families with multi-generational consequences. Our goal at Care and Prepare has always been that ACP would become normative behavior in Tarrant County, that everyone 18 years of age or older wouldn't think it unusual at all to have an advanced care plan, that ACP would be like voting or paying your taxes or caring for a neighbor. It's just things that good citizens do. Thank you for being here and for being willing to rethink what true patient-centered care can look like in your hospitals and clinics.
I want to thank Dr. Barker for his kind words. Today, he and his wife Sharon are off the grid minding the gap personally in the Great Northwest, and this is their first trip now that she is cancer-free. We will mind the gap here and say, what is ACP in the real world? It's more than a form. It's an alignment of values. And we've examined earlier the national and international articles and shown where when ACP documentation is increased, we see goal-aligned care. Many systems still default to aggressive care in a crisis. And honestly, it's not that ACP is broken, it's that we don't necessarily see what those ACP plans are at the bedside when we're giving care. So the problem is how and where is advanced care planning implemented and in real workflows. We utilize our standard questionnaire of Your Health, Your Way. This is an evidence-informed tool, and it helps us by looking at the evidence of how ACP works. And our clinic, we show where we do that. Every new cancer patient and caregiver is offered an ACP consult, and we are measuring those results. Approximately 45 to 55 minutes is our encounter time for an ACP consult. 1.4 documents are actually created per consult. So most people are able to easily identify a champion, somebody that could advocate for them, and they readily fill out a medical power of attorney that gives legal definition to what their goals are. The next document that's most utilized is an advance directive. You probably also heard it called a living will. This is a directive to physicians, families, or surrogates as to what this patient would want in a dire situation. We also ask our patients other questions to get acquainted with them, and we've asked them what hospital preferences do they have, or what do they know about certain procedures or even palliative and supportive care. Now, I hope that this information has piqued your interest in advanced care planning. If you would like to have us come back, something that we might do is translating ACP via AI to the community. I also think it would be very interesting to extend the model analysis to a multi-year data source. Dr. Mary did it for 2023. Perhaps we could do it for several years, and also see how translating our AI-based quality and cost ACP model would look like with your organization. Of course, one of my favorite aspects of advanced care planning is the ethical case for early advanced care planning. In other words, introducing it before a crisis. We thank you for your kind attention to this and appreciate your being here and your support. And we yield now. See if you have any questions for us as a team.
Yeah, Leah, I'm looking at the Q&A box and the chat box, and I don't see any currently, but please, people, if you have questions, put those in. But Leah, I had a question I would like to ask.
Sure.
And I know that Jerry touched on these as well in the video. When is the best time to talk about advanced directives?
Well, that's a great question. The best time is when you don't need it. Today is a great day to talk about it, especially if you're not in a health crisis. If you're over the age of 18, it is appropriate to begin discussing what you would want in case of a healthcare emergency, because none of us places a reservation with 911 for a healthcare event. Usually just happens, but thank you.
Yeah, let me ask you this. Jerry also in the video cited a survey where many people feel that in the healthcare system today, we're putting profits over patients. But here's a question. You know, if you take the time to really do ACP consults, is that something that's allowable to bill for?
It is, and it's not just for single use. As a matter of fact, it is recognized as being good practice to have this conversation periodically, especially if you have someone with a chronic disease or a terminal illness. It's not a one and done billing situation. You don't have to produce a document. You just need to have a patient-centered conversation about what they think it would look like to live well at the end of their life. And we start by just asking, what does it look like to live well now? And that usually informs what their values are going forward.
Right. That makes sense. Dr. Tietze talked about THCIC and she explained what it was. What is really involved in getting access to THCIC de-identified data and some of the sets of data that the state accumulates?
Yeah, I'll take that question, Mr. Love. First of all, THCIC data is available from, of course, the DFW Hospital Council. The 90 hospitals in this area use it, but it's also statewide. There's three aspects of the THCIC data that could be utilized. The first one has to do with that you are available a hospital in the state of Texas, and then you are contributing your claims data to the Department of Health. Therefore, you have access to the de-identified data. Second, as a university, the legislative body that in 1995 put the legislation in place wanted the universities to have it and to mine the data. They wanted the students, the professors, to research that data on an ongoing basis. So at UTA and any university, we actually get it without cost. And what we do need is an overlay to be able to access the data and utilize it. It's a GUI front end, such as a BI and business intelligence tool. And then the third part of it is you can actually buy it. The state does make some income based on the data, and there are third-party participants that pay good money for the data and can mine it themselves, and it is protected whenever they are sold. Steve, does that answer the question that you had?
Yeah, it did. And as you were talking, some more questions have come in. Let me see if I can cover these. Leah, one of the questions was, can you talk about the training of your people at CNP who actually do the consults?
Yeah, we have a unique approach to advanced care planning. We utilize our conversational guide, Your Health, Your Way, and it is focused specifically on their values. We have an apprenticeship program that we do with this also, and so our team has gone through not only the training, but also having a guide by their side while they are developing their ACP muscles in a patient consult. So it really is very helpful. Most other advanced care planning programs are simply classroom, but since we're so focused on bringing that into the clinical environment, we want our facilitators to have the opportunity to wrestle with those conversations with someone there to help them if they need coaching.
And here's a comment and a question. Thank you so much for your excellent presentation today. Did your study consider anecdotal evidence, how a person or patient's emotional and spiritual elements affect a patient's decision-making process? I served as a chaplain in an outpatient graduate academic clinic, and these two elements often impact and affect a patient's willingness to have discussions on this very important topic.
Well, you're exactly right on that. Most people have to be in a place where they feel safe to do that, and their spiritual and emotional health is a part of the moment that we are stewarding. I think the British Medical Journal, really topped it off when it said that the core competencies of our facilitators are so important because most people never have this conversation, but after they do, they're so grateful that they did. So yes, most of our facilitators in the past have been chaplains. They have been very successful, but of course we have trained physicians and all other healthcare disciplines.
Here's kind of a personal message to you, but I'll read it to you. This was an excellent presentation. Thank you. Great to see you again, Leah. Let us know how we can support your work, Scott Brown. So I thought that was a nice comment.
Well, I love Scott, and I'm going to give him a plug here because I was hoping to mention this earlier, but I wanted to make sure we had plenty of time. His mydirectives.com has changed the space of advanced care planning, and we actually encourage our patients to look at mydirectives.com to upload their paperwork that we prepare for them. Some of our clients are 70, 80s, and older, and they're not too much into technology, but more and more people are adapting mydirectives.com because of just their pristine website and attention to detail. I love Scott, and I think his mission is outstanding. He is a wonderful entrepreneur that got into advanced care planning because his own family story.
Yeah, good points. And there are many other people that are commenting on what a great presentation. But here's kind of a question. Excellent presentation. I would love to see a DNP project on this topic. Is that possible? Thanks, all speakers.
Wow, I think Dr. Mary, that might be a great question for her.
That is one of my colleagues, Dr. Kathy Brown. Absolutely. You know, they all know me as a data person, but I am an RN, I am a nurse, and I do care about patients. So this is great. This is why we wanted to do this webinar, to get the word out more. And UTA loves to get engaged with the community, and that's what Care and Prepare was about, is us involved with the community basis. So I've got your number, Kathy.
You know, here's a question also, and this may be for John. What are the technical skills needed to create the ACP app or other apps for clinical workflow improvement?
Honestly, just the ability to do a lot of self-research. The mobile app itself, I had experience through the UTA program, actually. Part of Dr. Tietze's courses teaches how to develop a mobile app to ask and, you know, be able to send out forms and help see how a patient is doing through their journey. And so I was able to reapply that into consultation forms.
Great. Thank you for that, John. Another question.
This is Dr. Tietze. I'll just add that's a no-code app. So you don't have to know code to run it. That's why I could teach it to John. An example is smart. Was it smart
Google
app?
App Sheet.
Okay, so there you go. So there's ways to do it. Well, and we can cover more of that in the next webinar.
Great. You know, another question, and you know, AI is what everyone's talking about today, and you mentioned AI. And the question is, what is the main AI tool needed for this type of analysis, and how do people learn how to use it?
Dr. Jawad, you want to field that one?
What?
Yes, yeah, just one second. I'm trying to click on my microphone. Yeah, so yes, AI was a very great help in this process of analysis. So we have the theory throughout our studies, but AI was a big help, especially Claude. Like especially the one you mentioned, I used ChatGPT, but for some reason ChatGPT sometimes was not giving me what I'm looking for. So I went and switched to Claude, and it was a great help, especially in when we did the analysis using the regression analysis, and it suggested also we have the output from the logistic regression, but also it suggested to use the PSA Monte Carlo, which is probabilistic sensitivity analysis, using Monte Carlo. And I mean, I knew about this information, but using this Claude suggestion, it was big advice to me to incorporate this PSA Monte Carlo to this analysis.
Great. Thank you.
You're welcome.
You know, I don't see any other questions pending, but these were some excellent questions and some very nice comments. So I really want to thank the University of Texas Arlington and Karen Prepare. And I will say this, for any of the people that are participating in the webinar that are curious about accessing the THCIC data that Dr. Tietze talked about, just let Chris Wilson know, and then he can put you in touch with the appropriate people in our foundation who do excellent work accessing not only our data, but data from THCIC. So we'll be more than happy to try to help you. There are licensure requirements, etc., but we'll be more than happy to help you. Again, I want to thank University of Texas Arlington, Karen Prepare, and I also think it was an excellent presentation. I think we've got a couple of minutes left, so I'll turn it back over to any of the speakers that would like to make any final comments before we sign off.
Well, Mr. Love, thank you so much. We really appreciate this time. I would direct people to our website, careandprepare.org, and please go to our materials and resources. We've got a tab up there that says Choose Your Champion. You just click on that. It'll take you right to the paperwork. If you're over 18, this is appropriate paperwork for you. If you want assistance in walking through that, you can reach us. So we would love for everyone to have advanced care planning for all. Hashtag ACP for all. That's us.
Okay, we just got a note that somebody lost sound, but I think can most people still hear? I'm not sure if that was just that individual.
We're still good.
Okay, we're good.
Yeah, I want
Any
to add
other
one more.
comments from the
I want
speakers?
to add one more comment. I want to thank Dr. Tietze for her unwavering support and direct advice that she gave us, which make us really form a wonderful presentation. One for her, I think we will probably have so many mishaps in this presentation. Thank you, Dr. Tietze.
Right.
I did my teacher thing, but this was a great group. I love collaboration, and I love the computer science and engineering department. I can't function without them anymore in this world that we're in. And if any school is interested, Mr. Love just said that as a school, you actually do get access to the THCIC data. There are several that use it. I'm more than happy to help with the schools using it more so.
Thank you.
That's all for me.
Okay, well, I think this concludes our webinar. Again, it was a very meaningful webinar. Hopefully it was information that was helpful in advanced care planning. So with that, two administrative things. If you registered for this webinar, you are going to get a copy. This is recorded. And I didn't ask Leah this earlier, so I'll defer to her. But if we get permission, we can share the slides with you as well.
Oh, absolutely.
Well, thank you very much. And I hope everyone has a great rest of the day. Thank you for joining.
Thank you.